Well, hopefully everybody had a good lunch. Hopefully people will start trickling in for this next session. I'm Jason Walmuth. I'm going to be the step-in moderator for Dr. Dangus, and Dr. Jay Khatri from Cleveland Clinic is going to be the co-moderator with me. This session is about bifurcation PCI, which I'm excited about because it's certainly one of the procedures that I dreaded doing in my early career, and now I've come to enjoy them quite a bit. So our first talk today is going to be by Dr. Lorenzo Azzolini from the University of Washington, and he's going to be talking about the latest clinical trials with bifurcation PCI.
Thank you very much, Jason. I already asked the course director for preemptive forgiveness on the length of my talk, but there is really a lot to cover. So my talk will be divided into 4 sections. I'm going to talk about consensus documents, then expert reviews, outcome data, and new techniques that have come out in the past couple of years. Let's start with consensus documents. So as almost every year, the Eurobifurcation Club came out with the consensus document where they outlined their main recommendation for bifurcation PCI. So they still endorse provisional stenting as a preferred technique for most bifurcation lesions. They go on outlining the optimal technique for provisional stenting with the importance of POT and pot-side POT as an alternative to kissing balloon inflation. Regarding two-stents technique, the choice of technique must be done according to bifurcation anatomy and operator experience, and they underline the importance of POT and final kissing balloon. I was a bit surprised reading the recommendation about imaging because the use is recommended just in case of complication and challenging, and not in most cases, particularly in two-stent bifurcation cases. Then there is like a discussion about the educational and training needs with stenting simulation, artificial intelligence, machine learning, and augmented or virtual reality. Another important document that came out is the Academic Research Consortium document on bifurcation. A lot of material to cover. A bifurcation lesion is defined as a coronary stenosis adjacent to and or involving an adequate size side branch, at least 2 millimeters in diameter, and significant stenosis more than 50%. Definition of true bifurcation, the document goes on underlining importance and unmet need in QCA for bifurcation lesions, and then we will see that more in detail, but basically how to evaluate the clinical and relevance of bifurcation lesion involving the side branch. So the side branch must be of adequate size, at least 2 millimeters in diameter, and then there is a set of criteria. It's very dense, and I invite you to read the document that basically can be based on angiography alone or angiography plus IVUS or OCT, coronary CTA, or myocardial stress test. Other things that the document covers is definition of clinical endpoints for trials and registries. For the first time, we have the concept of target bifurcation-related ischemia or revascularization, and both, like MACE, the equivalent is bifurcation-oriented composite endpoint of cardiovascular death and target bifurcation-related MI ischemia or revascularization. Another interesting document from multiple bifurcation societies is on the physiological approach for coronary artery bifurcation disease. So we all know from previous studies that there is a discordance between the angiographic severity of the stenosis and the actual functional significance of a jail side branch. And this is usually due to carina shift. So the carina just moves compressed by the stent. However, what is more relevant is if there is also a plaque shift. In a study, an FFR of less than 0.8 is a significant FFR, was more frequent in lesion with plaque shift superimposed on carina shift. So the document recommends the use of physiological indexes measured in the jail side branch after stenting to guide stenting strategy on the side branch and reduce unnecessary complex intervention. And these are a couple of examples from this report in which you can see, for example, on the left side of the screen, a provisional approach onto the distal RCA. They jailed the PDA here. It doesn't look good angiographically, but the IFR is frankly negative, so it was left alone. And the similar case on the marginal and circumflex system on the right. So basically, in case of a PCI involving a bifurcation, if the side branch is clinically relevant and after provisional stenting on the main branch, we see an angiographic stenosis, we should use either FFR or better, a non-hyperemic pressure ratio techniques to decide whether or not we need to do something on the side branch. What about extra reviews? So my group published recently last year an overview with a historical perspective on all the different iterations of crash techniques, from classic crash in 2003, step crash, DK crash, mini crash, nano crash, and DK nano crash. Another very interesting review published on the same journal, Neurointervention, by Mano's group led by Alison Hall, was on the step-by-step approach and troubleshooting of DK crash that I invite you to read. What about outcome data? So this is an interesting systematic review and network meta-analysis of 21 randomized controlled trials on true bifurcations. So it's important to underline that the DK crash trials from East Asia represented 28% of all the patient population. And in this study, DK crash was associated with fewer MACE driven by TLR compared with provisional. But digging deeper into the data, we can see that the clinical benefit of two-stents technique was observed over provisional, mainly due to bifurcation with side branch lesion length more than 10 millimeters, so complex bifurcations. Another very important study was the EBC main. EBC main randomized patient with true distal left main bifurcation to either two-stent technique that was 50% approximately cool out, 1/3 was tap, and just 5% DK crash versus provisional stenting. At 1 year, the primary endpoint did not differ between the two arm, and procedural metrics favored the provisional approach that was therefore recommended by the trialist as a default approach for distal left main PCI. And the reason for the discrepancy with DK crash 5 was mainly due to the different lesion length into the side branch, into the circumflex, 7 versus 16 millimeter on average in EBC main versus DK crash respectively. So different patient population, different anatomies. Another important study is both the 1 year and 3 year follow-up of the Definition 2 trial that included true complex bifurcation with a side branch of at least 2.5 millimeter, and 1/3 were left mains. So patients treated with a two-stent approach that was in almost 80% of patients, a DK crash, had suffered lower incidence of target lesion failure, a 1 year follow-up driven by pre-procedure MI and target lesion revascularization. And the results were maintained at 3 years. However, all the differences were driven in the acute peri-procedural period, mainly by procedural MI. Another study from the extended follow-up of the Syntax trial in which the authors analyzed the impact of bifurcation. So they saw that two-stent strategies were associated with higher mortality than provisional stenting, and the bifurcation PCI, but not CABG, in Syntax trial was associated with higher 10-year mortality. However, this extended follow-up lacked information about other endpoints such as MI and TLR. There's not very granular data on bifurcation technique and anatomy of this bifurcation, and also, despite adjustment, I think there is still a high degree of confounder, and especially PCI practice in Syntax is way outdated. It's more than 15 years old, with very little use of imaging and first-generation drug-eluting stents. What about new techniques, just to conclude? So we propose a variation of DK nano crash guided by live OCT imaging. You can see here mid-LAD lesion involving the second diagonal. After pre-dilatation, at the moment of stenting the side branch, we ran an OCT on the main branch, in this case the LAD, to precisely position with a nano protrusion the stent into the main vessel. So it's just a slight variation of the DK nano crash where we run the OCT at the beginning. And you can see here that there is just a small protrusion, 1.5 millimeter, into the main vessel, and you can clearly distinguish on OCT where the crimped stent is on the delivery system versus more proximal, where just the delivery system alone is located. And on the right side of the screen, you can see that this 1.5 millimeter protrusion was maintained, and then we obtained a good final result. This technique requires a 7 French or bigger guide, and it's quite tight in a 7 French, but it can be done. Importantly, it's better to advance the stent first and after the OCT. Another study brings up the concept of subinthemal shift in bifurcation PCI in the context of a CTO. So here we have a case where we were antegradally in the true lumen, the diagonal, but we were subinthemal into the LAD. So we went retrograde and we were subinthemal or extra plaque all the way from distal to proximal. And so if we had just stented with a provisional approach the LAD, we would have lost the diagonal due to this subinthemal plane, this dissection flap here at the diagonal ostium. So we perform a DK nano crash, obtaining a nice final result. On the same line, the Emmer group led by Wissam Jaber brings up the concept of double barrel crush technique for bifurcation PCI in CTO. So if we have dissection flaps due to aggressive techniques and in challenging CTOs, traditional two-stent techniques such as crush or culotte will leave one of the branch covered by stent struts and dissection tissue. And this will prevent easier rewiring of the side branch. So what they advocate is simultaneous kissing stenting or double barrel, in which there is a big protrusion of the side branch stent into the main vessel. After stent delivery, dual lumen catheter is advanced on the main vessel wire and is used to rewire the side branch with a high tip load wire such as a Gaia or a Confianza, and then the struts are open, kissing balloon and pot. So summarizing, there have been several recent consensus documents and expert review that are helping us understanding bifurcations better and spreading the optimal practices in bifurcation PCI. Physiology and imaging, once again, even in this setting, are allowing us a better understanding and hence treatment of bifurcation lesion. And rather than novel techniques, we've been witnessing imaging-based refinements of existing techniques. The jury is still out as to whether one or two stent strategies are better, as we discussed, this controversy between DK Crush 5 and EBC main. And the body of evidence in network meta-analysis is severely influenced by the DK Crush trials from East Asia. And in the future, we will see even more prominent role of technological advancement with dedicated bifurcation QCA, stenting simulators, and artificial intelligence, computational fluid dynamics software to better understand and treat bifurcation. Thank you very much.
That was a ton of information very quickly. Thank you so much for that. Lorenzo, I was just wondering if you could elaborate a little bit on the long-term medical therapy for patients who are treated with bifurcation strategy, 2 stents versus 1. Do you have a difference in opinion? And
so that's a very pertinent point, Jay. And I think in the Euro Bifurcation Club document, I didn't have time to discuss it, but it was written on the slide. They underline how bifurcation lesions, particularly after stenting, are a highly thrombotic milieu at high risk for thrombosis and also Resinosis. So particularly if there is a 2-stent strategy performing that bifurcation, I tried, if possible, to use long-term DAPT, even more than 1 year in certain cases, particularly if there's been, as mentioned, like a 2-stent strategy. If there is just a provisional approach, probably the thrombotic milieu is lower, and we might get away with lower DAPT durations. And in the same equation, we have to keep in mind that some patients are at high bleeding risk. So perhaps before choosing the bifurcation stenting strategy, we should take into consideration also the feasibility of long-term DAPT in these patients. So this is something that skews our decision-making probably towards 1-stent strategy in borderline cases.
So Lorenzo, again, congratulations. That was an amazing feat of summarizing a year's worth of publications in a little over 80 minutes, but that's okay. And then I have one question for you. There's a lot of confusion out there regarding the nano crash. What is nano crash and how do we do it? And you know you've done the DK now, of course, you go one step. But can you clarify for us what is nano crash and how it's different from the standard crash?
So, yeah, in the review we discuss all the different iterations. Sometimes, the classic crash by Antonio Colombo involved protrusion of 3 to 5 millimeters into the main vessel, creating a very long segment where we had multiple layers of stent struts into the main vessel. Then refinements of this technique were with mini crash, where I think 2 to 3 millimeters were involved into the main vessel. And nano crash, the more you decrease the extent of metal that you put in the main vessel, the smaller the unit of measure, so they call it nano crash. Then this interacts with decay, so there was decay crash, nano crash, and then decay nano crash. So it's a lot of confusion, and really also in decay crash, in decay nano crash, there are two different ways of doing it. There are two different papers, whether or not you should use a blocking balloon into the main vessel to finally position the nano crash stent into the side branch. And so really there is a lot of confusion, but beyond the mere nomenclature of all these techniques, I think we should keep in mind that the goal would be to minimize the extent of protrusion into the main vessel, and for sure we should steer away from like 5 millimeter protrusion like it was done like almost 20 years ago.
Questions from the audience at all? Yes. I'll bring the microphone to you so you don't have to hear.
Hi, Suresh Vijan, Bombay, Director of the Bifurcation Club of India. A couple of points to what, Lorenzo, you raised. I mean, we've been interacting with EBC for a long time and a part of the group that involves with EBC. Nano crush, to me, has an advantage that you do not actually cross multiple layers of stent when you're doing the second dilatation. The first time, your ostium is where the whole thing opens up nicely, and then you have just one layer of stent across it. You can go twice through that very easy, unlike the classical decay crush where you had 3 layers of stents across. And try and get the kind proximal crossing, distal crossing, all those issues related to that. With nano crush, what we do is actually use a balloon when we track the side branch back, so we get it placed just at the ostium or slightly ahead. You don't want to miss the ostia because then the whole point of doing the bifurcation is lost. So clearly, placement of the stent in the side branch is extremely important, and that's why they were pulling it back, and back. So I think we use balloon, assisted deployment of the side branch stent, and after that we proceed with the same stretch that we do, and the results are wonderful. So long-term follow-up, of course, awaited. We are in the process of writing up our first paper. Hopefully Jack will accept it, and then we'll see how we go. Thank you.
Thanks for your input. I think the way you do it is a really elegant way by having a blocking balloon there, and also the way that Lorenzo showed by using imaging to really see that you're truly getting it is great. But if you're going to do a mini crush, nano crush, you really have to do something like that, whether it's a blocking balloon or imaging, to make sure that you fully cover the ostium. Because, like you said, the worst thing that can happen is if you miss a bunch of, a millimeter or so or more of the ostium, or if you have it hanging too far back and then you're changing it to a true crush. And so I think your point is very valid that if you're going to be doing this technique, you have to be very meticulous in how you do it so that you fully cover the ostium, because missing the ostium in a situation like this and then having to go back and put a third stent in and doing some type of reverse crush or whatever is adding a lot more metal and probably not going to lead to the best long-term outcomes. So before we move on, I did want to introduce the rest of the panel here. I apologize, I forgot to introduce you guys sooner, but Jay Khatri from Cleveland, Michael Luna, Megha Prasad, and Poonam Velagapudi are also joining us. And then I think next we're going to be talking about provisional stenting troubleshooting.
One more question, if you mind, there's one more question here. Sorry.
Jason, thank you. Lorenzo, great talk. Fasha Forzanda from UH. Just from the panel, and so Lorenzo, what's your experience between different stent types, especially when you're dealing with left main? People are talking about radial force and access to the side branch. Do you feel any difference between any stent type drug-eluting things or not?
Well, in America, there are just 3 or 4 stents available. With contemporary drug-eluting stents, I don't feel there is an actual difference in trackability of these devices in bifurcations. So we know that for bigger vessels like aorto-ostial stenting, there is the Synergy Megatron that has a higher radial force. I don't have data to support use of either this stent or other stent for bifurcation PCI compared to other contemporary second-generation drug-eluting stents.
Can I just take that up a little further? Because we've shown, and it's part of the EBC document, that if you leave too many struts across the ostium of the side branch, you're going to get tissue overgrowth. And from one ostia, you then will have 3 ostia, and that's been shown to cause symptoms. We have FFR studies across saying you have to deal with that at a later stage. What we realize is you got to have a stent which has the minimal number of links in the main vessel. So if you don't have too many links, then links is where the tissue starts to grow, not just struts. And that matters a lot. So clearly, we feel that you need to go in with stents in the main branch with minimal number of links. Traditionally, there are 3 links. There are some stents now with 2 links. And that kind of makes that space a little bit more open. Those struts open up well. You have a nice opening at the side branch, and that helps. So I think minimal number of links would probably be the way to go.
Great, that was an amazing discussion. So we're going to move on to the next talk, and this is Dr. Human Khalili. I just lost the side branch provisional stenting troubleshooting.
All right, thank you very much for the invitation. Where's that? There we go. All right, so just briefly, Lorenzo went very detail about bifurcation, so I'm not going to recap the whole thing. But when to do provisional. So the first question you ask is whether or not the side branch is worth saving. So if you have a small side branch, less than 2 millimeters, it is likely does not need to be preserved. And the provisional stenting then is performed if you have a side branch that is worth preserving and the likelihood of side branch obstruction from the main vessel stenting is low. And you can evaluate that by angiographic appearance. Is there disease involving the side branch? Intravascular imaging can be very helpful to evaluate the amount of plaque burden in the side branch. Angulation of the side branch, whether or not it would be difficult to wire the side branch up front or in particularly after if you do run into problems of side branch obstruction. And lesion characteristics is calcification of the main vessel, is there thrombus. So let's say you decide to go down the route of provisional stenting strategy, don't think that you need upfront bifurcation, then we'll go down the path of provisional. So provisional strategy, as I'm sure most people are aware of, is you leave a side branch wire in and you stent the main vessel. The best way to avoid downstream side branch obstruction is to prevent that from happening. And one of the crucial steps, I think, of provisional is, this is a slide from Manos, is sizing the stent appropriately to the distal reference vessel diameter. So the top, I'm sure you can see, the top left figure is appropriate sizing the stent to the distal reference diameter, whereas the bottom left is sizing it to the proximal. What happens, as Lorenzo talked about, is criner shift, and criner shift can cause stenosis of the side branch. It can cause distal perhaps plaque shift, also can cause distal main vessel dissection or perforation. Another crucial step is that once you do stent the main vessel and you are trying to remove the side branch wire, is to pull it out very slowly. Do not pull hard. I've seen dissections, perforations of the left main due to aggressive pull of the side branch wire. And if there is any difficulty in removing that wire, you can use a microcatheter or the wire balloon to kind of get it all the way down next to the stent, perhaps even behind the stent. Most of the time you don't need to do that, and the wire can come out pretty easily. So you went ahead and did a provisional stenting approach, and then you assess. You assess the side branch angiographically to start off with. And if it's okay, angiographic appearance is good, you're good to go. So this is a case of a proximal LAD stenosis. It kind of looks like a Medina classification 100. Proximal main vessel is involved. There's a little bit of aneurysm distal to bifurcation. Side branch appears to be preserved. Significant amount of calcification, as you can see in the second figure in the middle. There's resistance to balloon dilation. And the question that comes up often is, would you protect the side branch? In this particular case, I don't think it's not that difficult to decision. There's not much disease involved in the side branch, but if you do want to protect that, you can put a guide wire down there, and obviously you can use a microcatheter. Microcatheter with protective wire from the atherectomy burr, be it orbital or rotational. And nowadays you have, of course, the option of shockwave as well, intravascular lithotripsy, which then in that case you're probably good to have a wire there without any complications. Word of caution, the microcatheter can get ablated, even though it protects it, so it would be good to move the microcatheter around during each run of the atherectomy. So in this particular case, there was no protection of the side branch. There we go. Balloon dilation was performed and pretty decent angiographic result with no compromise. Angiographic appearance is good and the side branch looks good. This is another case that, paying attention to that third diagonal, it seemed like the lesion was more or less a Medina classification, perhaps 011, or 010 rather, and the Proximal Lad, in this case the main vessel, was stented. You can see the ostial of that third diagonal artery appears to be pinched. This is exactly what Lorenzo was talking about. Angiographic appearance is one thing, but evaluate that by some sort of physiology. So FFR was performed of that diagonal artery, and FFR was 0.95, so it was left alone. So in both of these cases, there was no compromise of the side branch, and the provisional stenting was done as expected. Of course, then you can have side branch that is compromised but not occluded. Side branch that's compromised and not occluded, then creates another set of challenges. Having a wire down the side branch can be helpful, and this is a couple of cases. So this is a Medina class, I would say 010. The main vessel, you can see there's a lesion immediately distal to the large diagonal. The diagonal artery appeared to be preserved, and did not appear to have significant stenosis angiographically in the index image. Balloon dilation was performed, and the lesion was stented. There is clear compromise of the ostium of the diagonal. The flow down the diagonal also appears to be a bit sluggish relative to the remaining of the left coronary system. So consider that a significant ostial stenosis, pinching. So what to do in this particular case is, if you do have a wire down the side branch, that can help as a marker to rewire the side branch. And you essentially rewire it. You aim to rewire the stent at the distal stent strut, and you can see at in the image on the right side, wiring the stent through the distal stent strut allows for nice scaffolding of the ostium of the side branch, whereas wiring at the proximal followed by ballooning can cause protrusion of stent into the main vessel. So distal side branch wiring would be a preferred approach here. So once you do that, you can go ahead and then do kissing balloon dilations and reevaluate. If there's difficulty with wiring, there are always other options with catheters. There's angled catheters like Supercross is the top left, or you can have Ninja Swift, which is on the top right, or you can have a twin pass microcatheter. Twin pass is probably a preferred approach because you maintain that goes over your main vessel wire, so you're sure that the wire is going through through the stent of the main vessel, and you're not going behind the stent struts to get to the side branch. So that would be a preferred approach if you do have a dual lumen microcatheter available. And again, like I said, once you get across, then you do a kissing balloon inflation, do a proximal optimization technique, repeat the pot, and reevaluate. If there is angiographically improvement with improved flow, then you are done. If not, then you have to consider in that situation perhaps a stenting strategy. So in that particular case that I showed you, there was compromise of side branch. The side branch was wired, and a reverse crush technique was in this particular case performed, and the ostium was spotted, and this is the final result. So the third scenario would be that the side branch is occluded, and there is no flow down the vessel. Obviously, that side branch needs to be rescued. Hopefully you have a wire down there. If not, it may be a bit of a challenge to figure out where the side branch is coming from. So that's why the advantage comes in of having a wire in the side branch to kind of at least guide you to rewire it. If you have a wire down there and you're able to wire the side branch, then you can go ahead and balloon and go down a path of either trying to doing kissing balloon inflation or pod, or followed by pod, or if need to be stented, then there's the option in inverted decrush, which I'll get to. So this is a case of a patient presenting with non-anesthetic MI, came in with Proximal Lad disease. There's also disease here you can see in the ostium of the diagonal. Now you can argue that the side branch probably could have been or should have been wired here, but nonetheless the main vessel was stented with good angiographic result in the LAD, but the diagonal vessel, as you can see, is obviously in a worse shape. So what to do in this particular case, thankfully there is some flow down the diagonal, so you can have an idea where the side branch is located. Wired the diagonal vessel. This was just a workhorse wire. We start off with typically workhorse wires and then move on to a little bit more aggressive wires. The majority of the time workhorse wires works just fine. And then polymer jacked soft non-tapered wires would be my next choice, like a Fielder FC. The side branch in this particular case was wired, and again, same thing here, reverse mini crush technique was performed with excellent angiographic result. And so, what if you are unable to get a wire down the vessel, and if you have a wire down the side branch, and you're still unable to wire through the stent struts into the side branch, having that protective wire can be very, very helpful. This is the case from Manos' excellent representation of this exact scenario. So this is a circumflex CTO. It was expertly wired. There are two obtuse marginals. The obtuse marginal bifurcates here. The first obtuse marginal was wired. A primary anti-gray strategy. A twin pass catheter was used to wire the inferior branch. And the lower branch was treated as the main vessel in this particular case, and it was stented. Once it was stented, you can see that there is no longer any flow in that superior branch of that obtuse marginal artery, so you have a loss of complete flow. You do have a wire there to kind of guide you as to where to go. So that's where it comes in handy. Unfortunately, despite multiple attempts, however, they were unable to wire the side branch. So but the patient was having symptoms, had EKG changes. So again, where this JL wire comes in very handy. A small balloon was advanced over that JL wire with incrementally larger sizes. Flow was reestablished. Once flow was reestablished, and they were able to at least get the patient a little bit symptom-free. Again, multiple attempts were made to rewire it again through the initial stent into the side branch. That was unsuccessful. So then the strategy was changed to in this particular case, inverted DK crush. So again, the main vessel, this case we call the main vessel, right? Stent was crushed. A stent was delivered into the side branch, and that was crushed the second time with that stent. The main vessel was stented. Kissing balloon inflation pot was performed with great angiographic result. So the take-home points, I think, would be evaluate the need, obviously, for upfront bifurcation strategy. Use imaging often to determine whether or not the side branch needs to be protected. For provisional main vessel stenting, highly consider a side branch wire. You can always take it out. When removing a JL wire, however, do not pull hard. Use a microcatheter over the wire balloon if needed. A side branch wire is a great way to act as a marker and to rewire the side branch after the main vessel stenting. Use a dual lumen microcatheter if needed, and then kissing balloon inflation pod a lot of times can take care of these angiographic stenoses. If not, then you can proceed with a tap or a reverse crush depending on the angle of the side branch. And of course, if you can enable to wire the occluded side branch like the last case, you can balloon over a JL wire, reattempt wiring. And if that fails, then we can proceed with inverted DK crush. Thank you.
So a quick audience poll and panel poll, and I'd love to hear other people's opinion on the panel about this. With a provisional approach, do you put a wire in your side branch, and when? How many people always put a wire in their side branch if they can?
Almost always.
Or almost all or almost always? And how many routinely don't? Okay, good. And then I guess question number two is do people routinely jail their branches either in a side branch that hasn't been stented or even between two layers of stent, like in a culotte or something? Curious. How many people will jail wires with impunity? And how many people never jail wires or try to avoid it at all costs? See, all right. That's what I love about bifurcation is there's no right answer because everybody does it differently, I think. So curious, Poonam, what do you think? What was your answer and why?
I always protect when the vessel, I think the vessel's big, more than 2.5. Usually for smaller vessels, I don't worry as much, but it's always easier to wire up front than to have to go back when the vessel's down. And that I've learned by doing both ways, and so that's, since then I'm always wiring it. And I've never had problems pulling the jailed wire back, so it's just the cost of that additional wire.
And I think it depends how expert you think you are at wiring, right? Like that case I presented of Dr. Michael Luna, you know, he's very good at wiring very difficult lesions, but I think, at least for me, I find it difficult and I would panic. If I have a side branch that's occluded and I'm trying to wire it and patient's unstable, for me, I'm gonna have a hard time doing it. And I think that side branch at least give me a bit of security that even if I can't wire it, I still have that gel branch that I can at least reestablish flow, you know, get rid of the ischemia and kind of reevaluate.
Just to clarify the poll that you took, I think gelling a wire against the vessel wall with one stent is okay, always done. But we try and avoid gelling the wire between two stents. That's a disaster because that's going to shift.
But Jason, your comment is that you do that routinely,
I
right?
do it routinely, and it's never
With
been
both
an issue.
stents.
But
Between
I'm curious
two
about
stents,
that,
yeah.
Jason. So can you explain, like, what do you need that for? Because you now have a crushed stent as a target, right?
Yeah.
You don't need a wire to mark that branch. So
No,
what do you use that for?
That's a good question. I don't know. I would say that, well, the vast majority of the time now, I will do a DK crush. I don't do as much culotte or tap anymore. And so I do like to leave that wire in there because it does give you kind of a sense of where the ostium of that vessel is, because it's usually kind of crushed towards the superior part of the side branch. When you're recrossing through the crushed stent, sometimes it can be challenging, and so if you have that marker there, it kind of helps me kind of guide. I try to get the tip of the wire just distal to that marker. We try not to go through, unlike when you're typically, like with a provisional, when you're trying to go through the distal portion of that cell. With a crushed stent, you actually kind of want to go through the middle. You don't want to go through the distal because you'll actually pull it off the wall and end up the part of the carina in the side branch. And so I will leave it there just because it kind of helps with that.
So
I used to do it when I do.
I just want to understand and make sure the audience understands. You're saying that the wire that's in the crushed stent is helping you to select the appropriate cell to cross.
It will generally be on the upper part of the side branch, kind of the more proximal part of the side branch, because it's pushed up there. And so I usually will set my wire kind of almost like in a target between the carina and the upper edge of my stent where it's going across. So.
And I would also add that with jailing the side branch routinely, I think there was a study that it's an observational study with some adjustment, I think, but there was a lower incidence of flow limiting dissection and hence need for intervention of the side branch if there was a wire preemptively put there. But it's, you know, small studies and it's not a trial, of course.
Quick question and maybe clarification. When do you pull the wire from your side branch after stenting? Do you pull it before NCing and post-dilating, or do you pull it just after stenting? Because I always do it after stenting. If I stent looks good, the side branch is protected, I pull it and then do post. I never had issues. But I know some of my colleagues, they leave it until they NC, and a couple of times I've seen the jailed wire having difficulty come out. What's the group?
I do it after pod, but I don't know. Yeah, I do it after pod. Just to make sure if there's something going to go wrong, it would be after pod, it would be the final thing.
Stefan's dying to say
But
something.
I don't know.
I think once if you protect the branch, it depends on if it's a left main bifurcation, it's of paramount importance as soon as you've delivered the stent into the LED, let's say if you're doing a crossover over the circumflex, to get rid of the circ wire. The reason why is that a lot of operators forget about it and they try to reposition their guide. And the guide cannot engage the hub of your stent. You gotta just concertina your stent. So you gotta get rid of that. You just do an unselected shot, make sure that you have flow in your circ, and you get rid of that wire. Then you pot, you recross, and then you do your kissing, whatever the shenanigans you want to do. But the thing is that you don't want to concertina that stent, and that's a common mistake that's done even in live cases. I've seen tons of people not even understanding what they're doing, and they're actually pushing their guide with a wire that's underneath. The guy will not get anywhere, but just push the stent in.
Yeah, that's a good point. And also, if you have stented across your circumflex and you pull on that circumflex wire, if there's any tension on it, it'll pull the guide in and cause the same issue that Stefan pointed out.
Great. I think in the interest of time, we should probably move on. So our next speaker is my esteemed colleague, Jason Wilmoth, who will be speaking to us on bifurcation PCI, when to use the two-stent and how.
Okay. Thanks, Jay. We'll bring up my slides. Again, we're going to talk about how to use two stents and when to use two stents. Again, I think this is a really interesting topic because there's clearly not any profound consensus, but I think there are some general guidelines that we think that we generally go by. So I'm going to go ahead and move forward. I think probably the first thing that's really important is that we're all talking the same language. And over the years, there's been a ton of different bifurcation algorithms and classification schemes that have been used. But pretty much now, I think most people are using the Medina classification scheme, which is a binary classification scheme to identify the anatomy of the bifurcation lesion and where the lesion involves. So that you get a 1 or a 0 for the main vessel proximal to the bifurcation, a 1 or a 0 distal to the bifurcation. It's advancing without me. Can we go back? Oh, there we go. And then there's a 1 or a 0 for the side branch bifurcation. And typically what we would call a true bifurcation is a Medina 1-1-1 or a 1-0-1 or a 0-1-1, which means that there is disease in the main branch, but also disease in the side branch. But even with that, there can be some discrepancy, and I think a lot of that has to reflects some of the disparity in the trials that we see. And so when it comes to bifurcation disease, what are the options? Dr. Khalili talked about the provisional approach, which I think still in most cases is a reasonable upfront strategy. But then there's a number of two-stent techniques. There's the crush, mini crush, nano crush, or double kiss crush, kind of all that family, the culotte, the T stenting or T and protrusion stenting, and then there's V stenting, and then finally simultaneous kissing stents. The one thing I would say is I don't think simultaneous kissing stents should ever be used with one exception, and that is if it's to save the life of a patient. If you have a left main that's dissected down both limbs, and if you dilate one of the stents, you're going to lose the other limb. That would be one instance where I think putting two stents up at the same time would be reasonable. But in that situation, I think that's something that you would want to mandate to turn into basically a old-fashioned crush, where you end up crushing it, rewiring back through the double layer and kissing it open. And so really take simultaneous kissing stents off the table in the vast majority of cases. So, and I know Dr. Azzolini went through a lot of the data on this, and I'm going to highlight just a few trials and maybe give some explanation as to why we may have some disparate results. But, you know, a lot of the early bifurcation trials seem to favor the provisional approach. And I think a lot of that may be because these trials were done in patients that may have had true bifurcation lesions, but a lot of them may have not been the true bifurcation lesions where there wasn't disease in the side branch. But all of these trials really did highlight the value of a provisional approach. But when you look at these things, I want to highlight two things on this slide. One is that the two-stent strategy that was used in almost all of these trials was the crush technique. And really, I think that's a fairly antiquated technique, because with that, you're having to cross back through 2 layers of stent strut, one of which is deformed and crushed. And so really, in those trials, about a third of those cases, they couldn't even recross. And so you're leaving this patient with a large chunk of metal sitting in front of the side branch, and you wonder why they had a bad outcome. The other thing is that if you look at the publication dates of these trials, these were all about 15 years ago or more. Oftentimes, these were bare metal stents, or if they were a DES, they were with our large crummy first-generation stents like Taxus and Cypher, which again makes crossing through these and doing a good job exceedingly difficult. And so you can find an argument in the literature for any approach that you want. Here's a meta-analysis that showed that that supported provisional single stenting, but another meta-analysis just a few years later that shows that two-stent techniques are also very good. And so a few things that I think highlight the differences nowadays. One is that our current generation stents are probably better in doing bifurcation lesions compared to our old stent. This is data from the Nordic 4 trial where they actually broke it down between the first generation DES and the second generation DES and showed that those curves seemed to be a little bit better favoring our newer generation DES. Again, this was not statistically significant, but it certainly argued that. We talked a little bit about the EBC main trial, which showed equipoise between a provisional approach versus DK crush stenting, which again was different from what was seen in the DK crush 5 trial. But a couple things to highlight. In the EBC main, there was very few cases where they had DK crush as the bifurcation technique, as opposed to the DK crush 5 trial, where all of the 2 stent strategies were done with a DK crush. Also, as Lorenzo pointed out, the degree of disease and the length of the disease was different between those trials, where it was longer in the DK crush 5 trial. And so I think that might explain a little bit of the difference between these 2 trials. And then finally, I'd like to highlight the Definition 2 trial. And I think this was a really important trial because not only did it look at 2 true bifurcation lesions, but it really identified lesions that were highly complex. And so in previous trials, oftentimes the inclusion criteria for a significant lesion in the side branch was anything over 50%. But in the Definition 2 trial, we are just jumping forward here. In the Definition 2 trial, to be included, if it was the left main, the side branch had to have a greater than 70% stenosis with a lesion of at least 10 millimeters in length. And if it was a non-left main, it had to be a 90% stenosis in the side branch. Not only did you have to have that, but then they also had to have minor criteria like thrombus, multiple lesions, calcification, and tighter angles or more narrow angles. So it was really a much more complicated lesion subset. And I think when you're starting to look at the more complicated lesion subsets, I think that's why it explained the value of doing a 2-stent strategy that was seen in this trial over a provisional approach. So when do I use a 2-stent bifurcation strategy? Well, up front, I oftentimes will do this in patients that have a Medina 111, where there is really a significant amount of disease in that side branch. And likewise, Medina 011 or 101, where that side branch is A, of significance, B, with a tight stenosis, and C, with a relatively long lesion of more than just a millimeter or 2. And then there's a provisional 2-stent strategy. So oftentimes when you go in and you place your wires across your vessels and you do your initial angioplasty, a lot of times we cause disruption to those vessels. We cause dissections. And it's really important to have an armamentarium of 2-stent strategies so you can, on the fly, change your strategy if your vessel prep strategy has impacted the lesion, either losing a side branch or causing significant dissection, plaque shift, or carina shift into the side branch. The other thing to point out, and I think others have highlighted this, is that when you do stent over a side branch, the angiographic appearance is oftentimes overestimated. And there's a couple nice trials that I highlighted there. But basically, and in these trials, one of them included greater than 70% stenosis where they did FFR, and one was greater than 90%, I believe. And both of them showed that in less than 30% of the time were these of clinical significance and FFR positive. So what are the angiographic findings that influence our strategy? Obviously, the vessel size and the vessel shape play a big part. Well, one of the things that we'll look at is the size of the main branch relative to the side branch. We look at the size of the proximal main branch to the size of the distal main branch. And then finally, you need to think about your stent expansion characteristics. You don't want to do a culotte and put a 2.5 millimeter stent in your side branch and have that hanging back into a main branch that's 4 or 4.5 millimeters. You're never going to get that stent size right. So you want to be looking at vessel size and shape to help determine your strategy. We look at variations in the bifurcation and lesion. What's the side branch size? How much disease is there? What's the difficulty in wiring a side branch? I've had cases where I struggled for a long time just getting a wire across it, and that's not something that you then want to stent across because it's going to even make it harder oftentimes the next time to get through. We also look at the likelihood of side branch occlusion. If you're going to put a stent across that and you think it's about 50-50 whether you're going to have a vessel there or not when you're done, you may want to rethink your strategy. We look at the angle between the main branch and side branch, which again will affect which strategy we pick, and then obviously the location of the vessel as well. And then finally, as we mentioned earlier, we look at procedural complications. Is there dissection? Is there a plaque shift? Do you get a side branch loss or stenosis after initial vessel prep? So what are the options when you are going to use a two-stent strategy? I'm going to just highlight the three main categories: culotte, T or T and protrusion, and DK crush. So the culotte technique, again, is kind of that pant leg approach where you stent from the main branch across the side branch, rewire back through, and then put a stent into the side branch, having two layers extending into the proximal main branch. And I think this is probably reasonable for left main bifurcations that are Medina 111, but it really should only be done if the side branch size is fairly similar in size to the main branch, and if the bifurcation angle is relatively tight. I also would avoid using this technique if there's a higher risk of loss of the side branch, because again, you're going to have to stent over the side branch, and if there's a high risk of loss, then you may want to look at a different technique. T and protrusion, generally this is done as a bailout in provisional cases for me, but with this technique, essentially what you're doing is stenting the main branch and then rewiring back through, opening up the side cells, and then putting a stent in the side branch to cover the ostium, so you'll have a slight amount of stent that hangs back into the main vessel. And so this is an alternative to T-stenting where the side branch does not come off at a true 90-degree angle, which I don't know many bifurcations where that's the case, particularly after you stent the main branch. But you also don't want to do it where there's a very narrow angle because you'll just, to really cover the ostium, you'll have just too much stent hanging back into the main branch. This also should probably be done if the side branch is considerably smaller than the main branch, where you wouldn't want to be able to, or wouldn't be able to do a culotte to get the main branch stent expanded enough. And then finally, we'll talk about DK crush technique, and really this is kind of my go-to technique for two-stent bifurcation approaches. Really good for Medina 111 lesions. The initial data, like I said, was fairly crummy for the original crush technique, but again, it's because of difficulty crossing through two layers of stents, and oftentimes these were bare metal or cipher stents, which you were never going to get across. The double kiss really is the importance of it, because when you crush your first stent, the first kiss is, the whole point of it is to move stent struts away from the origin of the side branch so that when you stent across it, you're able to wire back through. And for me, this has become my preferred technique because I find it to be the safest and the most reproducible of all the techniques. And by safest, I mean you never have to worry that when you stent across the branch, you're going to lose that branch, because you always have the main branch protected because your wire never leaves, and you always have the side branch protected because you put a stent in it first. So for me, this is the go-to approach for most bifurcations. Manos had this, has published this in his PCI manual. This is a bifurcation treatment strategy he and I kind of worked on a few years back. And so there's a few things, like I noted earlier, that you want to identify: the likelihood of side branch occlusion, the relative size of the main branch and the side branch, and then the side branch angle. The first question we ask is, do we need to preserve the side branch? If it's small or if there's no disease in it, it really should be done with a provisional approach. But if there is significant disease in the side branch and it's a large enough size that it needs to be protected, you're going to want to consider a two-stent strategy. And then the next question is are you going to lose that side branch? And if there's any question in my mind that you're going to lose your side branch if you stent over it, don't stent over it. Just go and do a DK crush. If that risk is low, that's the time where I think you could consider other options. If the angle is fairly shallow, you can either do a culotte or a DK crush, but if the angle is closer towards 90 degrees, a tap may be a reasonable approach as well. So in conclusion, there are multiple bifurcation strategies. A provisional is certainly reasonable for relatively straightforward bifurcation lesions where there's not a lot of disease in the side branch, but you really need to know how to convert to a two-stent strategy and when that's necessary. And oftentimes that's not based on the angiogram because, as we noted, oftentimes that overestimates the degree of impingement on the side branch. An algorithmic approach certainly can be helpful based on vessel size, Medina class, bifurcation angle, and risk of side branch loss. It's really important that you're comfortable with the DK crush strategy, which again I think is probably the go-to for most people with a left main or in any bifurcation where there's a high risk of side branch loss. And the most important thing that I would say is on the last line, which is you really need to be comfortable with multiple strategies because oftentimes when you're in a procedure, things will change in the procedure that make you have to have the need to convert from one strategy to another, and you don't want to be learning that in an emergent situation. It's good to practice these techniques on more stable patients so you are able to use them in a more high-risk or urgent situation. Thanks.
That was fantastic. Jason, I want to go back to a discussion point that had already been raised. What's your technique to optimize the amount of side branch stent protrusion? Do you use imaging to guide that? Do you use a blocking balloon? And if you use a blocking balloon, how do you size that blocking balloon?
Well, I'll be honest with you, and that's why I was appreciative of the gentleman from India who kind of described his technique. I don't do a lot of nano crush or mini crush, and the reason is I've seen people do it and they turn it into a crush too many times, or they miss the side branch ostium too many times. And so I'm a lot more comfortable with just doing a classic DK crush. And you know, if you miss by a millimeter one way or another with a DK crush, it usually doesn't make much difference. And so that's my typical approach. But I think, as was highlighted when we were talking earlier, that if you are going to do a nano crush technique or mini crush technique, being very precise with your side branch placement, stent placement is imperative. And you can't really rely on the angiogram alone because oftentimes you're going to miss the vessel or you're going to have too much of it hanging into the main branch. So I love the idea of using a blocking balloon, and then Lorenzo's case where they used imaging, I think is paramount. So I think you have to be very, very meticulous if you are going to be doing that technique.
Yeah, and I would also add that in case you're unsure whether or not to go with one or two stent, even if it's not codified strictly into an algorithm, I think that imaging with ivosorosity, both branches, but in this case particularly the side branch, can tell you a lot about the plaque burden and the extent and characteristic of that plaque. So, you know, we discussed before about the superimposed plaque shift over the carina shift. So you can prevent that from happening by imaging. So you see if there is plaque into the side branch or not.
Comment, and then maybe we should go to the next one after the comment, so that because we're a little behind on the time.
Just about the balloon occlusion, I think you need to take a balloon size to your main vessel, and it's got to be at low pressure between 4 and 6. Don't expand the balloon too high because that will block the stent from coming in. So that's the issue with the size of the balloon. And just comment on the Medina classification. We find that not really helpful in planning a strategy. It's great to discuss with each other what we're dealing with. It doesn't take into account the bifurcation angle, doesn't take into account the fact that there is calcification or not, or whether there's thrombus or not. And that actually interferes and determines what the long-term prognosis for those patients are. So yes, it's a great classification, but we need to consider these, particularly when we're planning a procedure, particularly we're planning a two-stent procedure.
Yeah, I think that's a great point. And that's why I tried to highlight in the definition trial where they were not just Medina 111 lesions, they were 111 plus. They had a lot of other issues with them. And again, that gets to some of the difficulty in speaking the same language when we talk about bifurcations, is a lot of us have different ideas of what a true bifurcation is and what it isn't. So we're going to go ahead and move on. So Dr. Chadiel Reyes is going to speak about physiology and imaging for bifurcation PCI.
Thank you. Thank you for having me. I have slides. Okay, thank you. So I was asked to talk about physiology and imaging for bifurcation. I think majority of the topic already covered with the previous talks, but I'm just going to maybe give you a debrief again. These are my disclosures. So the best use for coronary physiology, as we know all, for assessment of ischemia and ACS for non-culprit, as well as for pre- and post-intervention PCI evaluation. Also for CABG planning, we're going to show some examples, and lately it has been used more for valvular heart disease evaluation now since we have a Lundquist off the market. Starting with a case, 65-year-old presenting with unstable angina. He has multiple comorbidities, as you see there. Stress test showed inferior lateral wall reversible ischemia. He's on optimal medical therapy, but he continued to have chest pain, therefore he came to the cath lab. The things we have to think about physiology and imaging is, number one is the recrossing challenges. As you have illustrated earlier, you have bifurcation, you have 2 stent technique or 1 stent. The physiology wire we have now and are not really very good for recrossing. And also an IVUS OCT are phenomenal tools, but crossing stent truss can be challenging. So depending on the size of the side branch and myocardial bed size and supplied by the side branch, this is also important when you are evaluating side branch stenting. Ulcer lesions are also harder to cross, and also how to deal with jail side branch. Going back to the case, again, as I said, inferior lateral ischemia, RCA is non-obstructive and some mild disease, but again, the LAD has kind of multiple tandem lesions extending from the proximal to mid to distal, and also the circumflex is heavily diseased, especially with the OM that fills from left to left collaterals. So again, just to zoom in on the left system to focus on it, again, as you see there, it's multiple tandem lesions. So we decided to proceed with IFR to see what is the best option for this patient, especially he has angina. So the plan is to do IFR of the LAD and perform a pullback and see if this is a diffuse disease versus a focal disease. I think it's already covered in a previous talk in different sessions. And also to evaluate the circumflex if that's involved, and maybe is it a left main disease or not. So as we all know, the techniques is you advance the pressure wire, you normalize in the aorta, you give it a good flush, and you empty all the contrast, and then you advance distal to the lesions, and eventually you do your measurements. So we started with the left LAD, where I advanced the distal LAD, introducing needle, we remove the needle introducer, and you flush the system one more time. Some practice, and learned that from Dr. Morton Kern, before you advance the wire, you can also use some nitro to rule out any spasm. But at this point, once the wire is distal and you're going to start doing the measurements, it's advised not to do nitro because that can induce hyperemia. LAD, as illustrated, he's 0.77, suggesting a significant ischemia in the LAD territory. And then when we did the pullback, you can see that, especially with paying attention to the blue line, is diffuse disease, is maybe some step-ups, but is on the other side is diffuse disease. When we did the circumflex, and this time we advanced the wire into the 3 branches, which is of the OM, it was a clear step up, and that tells you that this is a lesion, this is a focal stenosis, and just for the practice, we have been either wherever you put that wire, you're going to have the same result because the lesion is high grade in the mid segment. Just to highlight a few things about diffuse versus focal, again, as you mentioned earlier, the left side is the LAD is diffuse disease. Regardless how much stent you put in that LAD, you're not going to have an optimal results. But the focal lesion, this is where the IFR is really helpful in identifying, and co-registration can help you identifying where is exactly the lesion. As we're pulling out to kind of finally evaluate the patient from the left main disease, and indeed his MLA was 3.7 millimeter square, suggesting 70% stenosis. So based on this, when the patient was evaluated by surgical team or heart team, and because of his low STS score of 65, patient went for CABG. Again, this is to complement on the how physiology and imaging can help you guiding your therapy. Stepping it up a little bit to 85-year-old woman, chest pain, multiple comorbidity, end stage AFib, CVA, ejection fraction still preserved, but yeah, she has the wall motion abnormality and she has a multiple medical therapy. On the right side, as a RCA CTO and fills collaterals coming from the LAD, so LAD and that diag is filling into that RCA, and the circumflex also has mild disease but not very clear. Just to zoom in and give you different views, LAD has a very high-grade lesion in the mid area, and at the takeoff of the first diag and the second diag might be involved as well, and it's a good size visual, at least 2.5 millimeter visually, and we confirmed that with IVUS. So again, we went to evaluate the LAD again with IFR, advanced award to this LAD. You can argue you could have straight ahead fixed it, but again, we wanted to make sure that the physiology is involved to have optimization for pre and post intervention. This has been acquiring this practice lately after we acquire a new pressure wire that's better than Verata. We're advanced with this LAD, introducing needle and removed, again, flushing the system, make sure all the steps are done, and no surprise, the LAD has 0.76 lesion. It's a severe disease. And then we did the diagonal. Diagonal which is the second diagonal. Of course, the diagonal is already disease, as you see, as high grade, is 0.91. So it's a kind of borderline lesion, but again, it fills a lot of collaterals going to that RCA as well. Circumflex was IFR as well, 0.94. Again, we have an RCA to remind you that CTO, LAD disease, as well as borderline diagonal. When we did IVUS, now to complement that with the IVUS, again, as we all mentioned earlier, IVUS, maybe we're doing too many steps, but these are to give you more optimized PCI, and we couldn't advance the IVUS beyond that. This is a short tip IVUS. We don't have in our lab OCT, and the patient has a kidney disease, so she wouldn't be a good candidate for OCT because of the GFR being 30. So calcification, again, involving more than 180 degrees. So there I'll have to do some debulking, and that will be at risk also for the side branch to get more compromised. So 85 comorbidities, as mentioned earlier, LAD disease, RCA, CTO, left circumflex is good, and CABG versus PCI, but again, we opted for PCI because of the high STS score. So because of severe calcification, and we opted for shockwave, we use a 3.0 by 12 balloon in the mid as well as mid to distal LAD. We did 5 treatments total, 10 pulses per treatment, as you all know. And then after, this is the left side after PTCA and positioning the stent, and then we're gonna do across that at the diagonal. Now, the fact that we did not protect that diagonal, because when we did the IVUS of the diagonal, it was 2.75 kind of lumen, so we felt that's gonna be okay without protecting it. Again, this is showing the inflation on the right side and deployment of the stent on the mid to distal mid LAD. And then IFR post-stent was 0.89. So again, post-stent, it will improve from 0.77 or 0.75 to 0.89, still abnormal. So pull back to show up if there is any step up, and what is the step up? Are we missing a lesion distal to the stent, within the stent, or proximal to the stent from plaque shift? This is a nice algorithm. I saw it on Dr. Morton Kern's one of his talks, and published in Korean Journal Surgery, again, cardiovascular intervention. So if you, number one, if your post-PCI FFR or physiology is low, you have to rule out certain things. Are you having a drift? Do you have to normalize again? Is your wire having issues? Or an inadequate hyperemia if you are opted for FFR? Or it's a vasospasm, you have to give vasodilators. Again, if this is ruled out, major pressure step up, again, maybe this is a stent within the stent problem or distal. This is where you do kind of complement imaging as well as pull back to see where's the problem. Again, we felt that on the pullback, this is most likely in the stent. So we did a post-dilatation with a 4.5 by 20 high inflation with like 20 atmospheres and the mid segment. Again, the more inflation you do, the higher pressure, the more compromise you are putting that pressure on that diagonal. We're keeping that in mind. So this is pre and post intervention. Again, we have to make sure that we want to reevaluate that diag. But again, these are the challenges that I just mentioned earlier. Recrossing challenges, especially with the pressure wire we have now, that are not considered a very like a whisper or any other high-profile wires. So that's going to be a challenge. IVUS and OCT, if you want to evaluate the ostium, how reliable are these and how can be crossable, depend on the side of the science branch and how much the myocardium is supplying. Is this a branch that is really supplying a major area, which is IFR will be important, or is a small territory? We'll show you some example. And is the side branch is providing collaterals? This is also from a different talk. Bifurcation imaging, it depends on the angle of the branch origin of the side branch and the effect on the visualization of a bifurcation and osteal lesions. So it depends how you're looking at the angle. Sometimes you get foreshortened as you're advancing your IVUS versus you are really at a particular angle. You can identify the side branch. So you have, so the imaging, regardless how much you use, it can be, the angle can be obscured and under or overestimating the stenosis. FFR versus OCT, on the other hand, FFR, I mean, as you see area under the curve, 0.757 in this study. Again, it's kind of reliable to evaluate side branch compromisation post left main, main branch stenting, but OCT considered more accurate. Again, we are going into the vessel, you are measuring the lumen, but again, the crossability is a challenge. The concept that also you have to keep in mind is the role of myocardial bed size by the FFR. So if you have a 50% lesion but supplying a large territory of the myocardium, like in this case, FFR will be significant compared to an 85% lesion that's supplying a small area or territory in the heart. That's going to be normal. So final post-PCI FR was 0.95 on the LAD, and we were able to eventually rewire the diagonal was 0.91. So we stayed where we are in terms of diagonal. We did not compromise that lumen, but again, the LAD, we gave the patient the best result, especially now we have the GPS PCI trial enrolling for patient for PCI, and I think the cutoff they recommended is 0.94. And again, this is the final angiogram in different angles showing well-apposed stent and good more supply to the right coronary. Again, this algorithm I find it is very helpful in terms of complementing IVUS as well, or imaging as well as physiology in evaluated post-PCI intervention. Again, in terms of coronary physiology, it's guide definitely the treatment strategy, it's post-treatment assessment and evaluate non-culprit for ACS. But the bifurcation lesion for physiology is bifurcation are complex and PCI puts two vessels at rest, not just one. Angiographic assessment are limited. IVUS and OCT are an anatomical tool you can use. FFR useful at staging the PCI. FFR can reduce unnecessary step and reduce complexity. Like in this case, we did not have to do 2 stents in this vessel. And outcome of FFR PCI for bifurcation have mixed result. Thank you so much.
Do you think that was a great talk. Should we skip the discussion for the interest of time? We're a little behind in the session.
Thank you. Thank
Okay,
you.
great. So up next, Prashant Kaul is going to talk about left main PCI, in whom and how.
Good afternoon, everyone. Thank you very much for the invitation. Over the next 8 to 10 minutes or so, I'd like to just give you my thoughts on left main PCI, how to do it, and in whom. Here are my disclosures. So the most recently updated guidelines give CABG, bypass surgery for left main, a class 1 indication. Everything else related to left main and PCI, left main and imaging still has a class 2A recommendation. The one caveat of this is that the data that inform the recommendation for the class 1 indication for bypass surgery is over 40 years old now. And it's data from these studies from the 70s and 80s that compared bypass surgery to medical therapy. In an era when medical therapy was very limited, with only 66% of patients on beta blockers and less than 20% of patients taking aspirin in these studies. It predated the use of statins, ACE inhibitors, and contemporary treatment with P2Y12 inhibitors and so on. So, but we're now in the era of more recent trial data with for left main PCI versus CABG. And of course, Noble and Excel were the most recent studies. And looking at this data in aggregate and looking at the meta-analyses of these studies, the summary of this information is as follows. The outcomes, the hard outcomes, are similar for PCI and CABG for left main disease. There may be higher procedural MI and stroke rates for CABG, and so maybe favoring PCI in the early stages. However, there is this is offset by a higher spontaneous MI rate and higher revascularization rate in longer-term follow-up with PCI. Having said all that, though, in the real world, most of us, when we're faced with left main cases and doing left main PCI, these are often surgically ineligible patients, either because they're too high risk from multiple comorbidities or because of patient preference. So what I would say is that it may be difficult to generalize some of this trial data and apply these findings to unrestricted patients in routine practice that we see commonly. But that said, we still need to make a decision about how to revascularize a patient with left main, and I would submit to you that that needs to be done with a heart team approach And this decision-making is quite complex. And the variables to consider here are the ability to achieve complete revascularization. What is the surgical risk of the patient? What are the resources available, and what is the operator expertise? Patient preferences. Is this osteal disease and shaft disease, which clearly is much more straightforward than distal bifurcation disease? So this is a decision that needs to be made, but once you've made that decision, how do we do this? When we think about contemporary left main PCI, it should initially be done by an experienced operator at a site that has the availability and expertise with imaging, physiology, and mechanical support. Having said that, though, mechanical support is not needed in every single left main case. And if there's any concern or question, consider right heart catheterization to inform your decision. I would also submit to you that you can do most of these cases radially via a 6 French guide. Personally, with the advent of thin-walled sheaths, I like doing the 7 French radial. And remember, as we've heard now from several of the previous speakers, a provisional stenting approach may be better, although we'll discuss this a little more in detail. And in general, be familiar with these 3 most common 2-stent techniques, and remember to do a final kissing balloon inflation at the end, whichever strategy you're doing, as well as a proximal optimization. A word about imaging. We know from several observational studies that IVUS use is associated with an independent and significant outcome benefit when performing left main PCI, both regarding mortality and stent thrombosis, restenosis, etc. But really, the true prognostic effect of IVUS guidance for left main PCI is probably going to be confirmed by several ongoing randomized clinical trials that should really put this subject to rest. But regardless, I think most of us would agree that in 2022, you should not be doing left main PCI without imaging, both for pre-interventional lesion assessment as well as post-interventional stent optimization. And remember that most people would accept a 6 square millimeter MLA as a threshold for an indication for assessment. I think we have reasonable data suggesting that deferring lesions that are over 6 millimeters squared MLA is safe to do. And you may have seen this 5, 6, 7, 8 rule, which may actually be updated with data from the Excel study forthcoming. But remember, post-stenting under expansion was an independent predictor of bad outcomes, especially repeat revascularization. So let's just end with a few cases here to put a lot of what we've heard already into practice. So when you're thinking about doing osteal left main PCI, here's a case. This lady was in her mid-90s, actually, but insisted that we do something because she wanted to go to her daughter's wedding, or granddaughter's wedding in a few weeks' time, and could not walk across the room without angina. She had a lima to her LAD, so effectively this is a protected left main, but high-grade osteal left main disease and a high-grade lesion in the circumflex. In my mind, the hardest part of these osteal left main or shaft cases is to find the right angle to see the ostium of the left main clearly. Personally, I use a shallow LAO view to really see the ostium and make sure, because really the key here is to ensure there's no geographical miss of the left main ostium and you don't have the stent hanging out too much into the aorta. Many others will use an LAO cranial view, but find that view. It'll be different in different patients, but find that view and then place your stent accordingly. Because of the geometry of putting a rectangular object, i.e. the stent, into this left main, which is often at an angle, there's typically going to be some element of stent struts that are hanging out, but you want to try and minimize that while maintaining osteal coverage. And so here we got a nice osteal result here, and the rest of the circumflex looked good. She was happy and was able to go to her granddaughter's wedding. Now let's think about some of the bifurcation strategies. And as we've already discussed, provisional stent may be the best option in the first instance. So here is also another 90-year-old who this time presented in cardiogenic shock, ongoing chest pain in this EKG with ST elevation in AVR and profound ST depression in the other leads. And he came up to the lab, and this is what we see, a very high-grade mid left main lesion, extending then into the proximal circumflex. Given his EDP above 40, his hypotension, we opted to use hemodynamic support up front. This is a 7 French EBU guide via the radial approach. And we ended up using a 1.5 rotablator burr to modify the plaque there and some predilation. There was then a single stent left main into the circumflex. And then we recrossed into the LAD and dilated that with a final kissing. And this was a provisional strategy. On IVUS imaging, the ostium of the LAD was preserved. We did not need to place an additional stent. This was a single stent, subsequently a single stent strategy, left main into the circumflex with a nice final result. Okay, but what about if you do need 2 stents? And these were the EKGs pre and post, nice recovery of his ST segments. So we've already heard from Jason quite nicely about these 3 techniques, and I'm just going to re-amplify the messaging that he's already given you with some actual cases. So let's look at this case. This is a T and protrusion technique, high-grade left main, proximal LAD, proximal circumflex disease with a dominant circumflex system. So the circumflex here was a little bit larger than the LAD. So again, we initially we initially wired all the branches, pre-dilated the LAD. This is intravascular lithotripsy shockwave of the proximal LAD and the left main. And then we stented the prox-mid LAD and the circumflex, and then focused then on the bifurcation. And in this case, given that the circumflex was the larger branch, we opted to place a stent left main into the circumflex as our initial stent. Did proximal optimization, recrossed into the LAD and opened up the cell struts. And then this was our T and protrusion next here, where we placed a stent in the LAD ostium. And remember, when you're doing this technique, you need to place the second balloon in the vessel, in the other branch vessel, before you deploy the LAD stent. So now the LAD stent is being deployed, as you see in the right panel, and then both the previous balloon that you placed in the side branch and the delivery balloon are brought back together to perform your simultaneous kissing inflations. So that completes the T and protrusion. Nice final result of both branches. Okay, and here's another example. This time we opted for a culotte. You could equally have done a DK crush here. But very high-grade calcified disease. In this case, we needed to, there was no way any catheter was crossing this, so no imaging catheter was able to be put through this, obviously. But both branches were, sorry, this, there we go. Atherectomy of both LAD and the circumflex branches were performed. And then the left panel, this is our angiogram after just the initial atherectomy, so a nice result. And then this is how we did the culotte. So I guess technically an inverted culotte. So initial stent, left main into the circumflex, recrossed into the LAD after rewiring, placed the LAD stent and used the delivery balloon for a pot, recrossed into the circumflex, and then a final kissing balloon inflation for a nice final result at the end for what was a very heavily calcified and nasty-looking initial left main. So then finally, let's just think about DK crush. You've heard already that's sort of gained a lot of popularity in recent times. I will say that, you know, the only sort of just to play devil's advocate here, this is data, all the DK crush data is from a single site, but just to kind of go over this, the way to do this is you wire both, dilate both branches, deploy the side branch stent and perform proximal optimization, crush the side branch stent, rewire the side branch, ideally through a proximal strut, and do your first simultaneous kiss. Deploy the main branch stent, and do proximal optimization, recross the side branch, and then do your second kiss. This is why it's called the double kiss technique. Final proximal optimization, and then you want to make sure you image at the end. So this is my last slide. Just to summarize then, we've discussed that in the real world, there may be somewhat limited applicability of the trial data that we've all seen. Many of these left main cases that you see are surgical turndown cases. The decision to do left main PCI is quite complex. A heart team approach is essential. Be sure to understand the 3 most common two-stent techniques. I just want to underline something that Jason said. Many of these techniques and these cases that you've seen, going into the case, we weren't exactly sure which technique we were going to use. And after the initial pre-dilatation of both branches, our decision of which technique to use evolved based on how the geometry of the carina has changed. So be able to be flexible and facile with changing your techniques and be able to go easily from one technique to another. Please use imaging, both pre and post, and remember to do a final kiss at the end with repeat part. Thank you for your attention.
Great talk, Prashant. We are coming up on the hour, and we still have one more talk. So why don't we do the last talk, and then we can do a final panel discussion. Okay. So our last talk is going to be Approaching Stent Failure by Sal Alina.
Good afternoon, everyone. Over the next few minutes, I'll talk about how I approach coronary stent failure, and mainly focus of the talk would be management of in-stent resinosis, which is by far the most common cause of stent failure. We know that the risk incidence of ISR has decreased with the use of drug-eluting stents. However, it still remains significant. We have the NCDR data from 2020 that shows that about 10.6% of all PCIs are being done for in-stent resinosis. Even with contemporary second-generation drug-eluting stents, the risk of target vessel revascularization secondary to in-stent resinosis is ranging from about 4 to 8.6% at 4 to 5 years. So approaching the stent failure, the first question that I ask is if there is an indication for coronary artery bypass graft surgery, and if the patient is a good candidate for coronary artery bypass graft surgery. Here, for example, a middle-aged male patient presents with angina and has multiple coronary interventions in the past. He has a CTO of the mid-right coronary artery and has in-stent CTOs of the LAD and a large obtuse marginal artery. Certainly a very complex disease, and strong consideration for bypass has to be done in this clinical scenario. If the patient does not have an indication for bypass, the management of in-stent resinosis mainly is done by the mechanism of underlying in-stent resinosis. And to facilitate and to evaluate that mechanism, you need to have intracoronary imaging. And there, as per the Waxman classification, there are 5 types of in-stent resinosis, with type 1 being the mechanical failure secondary to either a stent under expansion or a stent fracture. Type 2 being biologic with neointimal hyperplasia or neoatherosclerosis with or without calcification. Type 3 mixed, type 1 and type 2. Type 4 are occlusive in-stent resinosis, mainly involving the CTOs. And type 5 is when you have more than 2 layers of drug-eluting stents already in place. Coming to the type 1, the stent under expansion is by far the most common cause of type 1 stent failure. And there is an algorithm that we can use for stent under expansion. These can be first approached with high-pressure balloon dilatation, either with non-compliant balloons or with plaque modification balloons, which if fail, we can use intravascular lithotripsy, which has certainly been revolutionizing the treatment of percutaneous coronary intervention. Opium balloons, which are high-pressure balloons, can be used. Laser with contrast does not work very well with severe calcification, but can sometimes help with passage of microcatheters or balloons. And if all these mechanisms fail, then atherectomy has to be considered. Orbital atherectomy is usually reserved for older stents, while rotational atherectomy can actually be used for both older and newer stents. And if these fail, then really have to consider dissection re-entry techniques or coronary artery bypass graft surgery has to be readdressed. This is an example of a patient who presents with angina and has type 1 in-stent restenosis. As you can see, he already has 2 layers of stent with outer layer very well expanded, and the inner layer is severely underexpanded. In this particular case, we did laser atherectomy. This was pre-shockwave. Laser atherectomy is performed with contrast, followed by high-pressure balloon angioplasty with excellent angiographic result. Another type of type 1 in-stent restenosis secondary to mechanical failure is stent fracture. And stent fractures have been associated with significantly higher risk of not only in-stent restenosis, but also stent thrombosis. And these can be classified based on the severity of stent fracture. Management options for these cases include either restenting or coronary artery bypass graft surgery. Yeah. There we go. Yeah, I think it's broken. So hopefully this will work. Yeah, so going back, this is a patient who presented with, who has in-stent restenosis of the left main LAD and left circumflex arteries. Let's go back again. So, well, I'll leave the images like that. You can see it on the picture. Severe in-stent restenosis, and in this particular case, intracoronary imaging was done that showed stent failure, and in stent failure secondary to stent fracture. And in these situations, stent boost images or clear stent images are really, really helpful and certainly can identify the underlying mechanism. And in this particular case, we had to do balloon angioplasty and followed by DK crush, stenting of the left main LAD and left circumflex arteries with good angiographic result by angiogram and with intravascular ultrasound. The type 2 in-stent restenosis is biologic in-stent restenosis, which can be due to neointimal hyperplasia or new atherosclerosis, which can subsequently become calcific, certainly posing further challenges in the treatment of these lesions. And the management of these is, we have multiple options. The balloon angioplasty can be performed with high-pressure balloon angioplasty. However, the recurrence rate for these still remain pretty high at about more than 50%. Plaque modification balloons can be used. Certainly, the drug-eluting stent have been the best treatment option in these situations. Drug-coated balloons are not available currently in the United States, but have been used outside of the US. With calcific neoatherosclerosis, it is important that we do calcium modification strategies. So in this study, this was a meta-analysis of 10 randomized controlled trials in patients with in-stent restenosis that compared the use of the drug-eluting stent versus drug-coated balloons in these patients. And this pretty much showed that drug-eluting stents have a better result, have overall better outcomes as compared to drug-coated balloons with decreased risk of target lesion revascularization. Another meta-analysis that was done pretty much showed very similar results. And overall, the conclusion from these studies were that for a drug-eluting stent in-stent restenosis that we are seeing more often, drug-eluting stent placement, placement of another drug-eluting stent has better outcomes when compared to the drug-coated balloons. However, for bare metal stents, drug-eluting stents or drug-coated balloons have equal rates of target lesion revascularization. This is a patient who presented with severe in-stent restenosis of the proximal LAD stent. OCT was performed that revealed severe diffuse neointimal hyperplasia. This patient was treated with balloon angioplasty followed by another layer of drug-eluting stent with excellent angiographic result and also with subsequent imaging. We come to type 3 in-stent restenosis, which is a combination of mechanical failure plus biologic. And we are seeing this more often because we know that in-stent under expansion is also a risk factor for neointimal hyperplasia. In this particular case, with severe diffuse disease in the proximal to mid-right coronary artery, intravascular ultrasound was performed. And this revealed not only significant stent under expansion, but also a severe diffuse neointimal hyperplasia. And in this patient, and these situations where you have multiple mechanisms, the treatment is individualized to the lesion type, and also multiple treatment modalities have to be considered. Initially, the lesion did not respond to high-pressure balloon angioplasty. The shock wave balloon did not cross initially. We subsequently had to use a laser atherectomy with contrast that allowed our, still with suboptimal result. Then a shock wave balloon, however, was finally be able to advance. We delivered all the pulses in the proximal to mid right coronary artery with good expansion. And subsequently placement of another drug-eluting stent, mainly to treat the neointimal hyperplasia that was present. So important thing to consider here is even if you have to put another layer of drug-eluting stent, it's mandatory to make sure that the previous stents are actually very well expanded. Coming to the type 4 in-stent restenosis, which are the occlusive in-stent restenosis from chronic total occlusions. Special mention is on the pattern D, in which the CTO extends beyond the proximal and the distal edge of the stents. These lesions are hard to treat. Even with our conventional modern CTO PCI techniques, the technical success rate for these procedures is about 75%. And we know that although the CTO PCI success rate for in-stent restenosis is very similar to the de novo CTO PCI, however, in the long run, there's a higher risk of target lesion revascularization and for major adverse cardiovascular events. In this patient, this was an elderly male patient who's already had a prior bypass surgery and has a pattern B in-stent restenosis, which is occlusive. And there were no good retrograde options. You can see a very tortuous epicardial collateral from the LAD, which is in turn supplied by the Lima graft. In this case, we decided to perform antegrade wire escalation, which of course did not work, and had to go around the stent, perform antegrade dissection re-entry. And many times, we may not be able to wire through the stent struts and therefore have to go around the stent struts. And in this particular case, we did ADR, re-entered into the posterior lateral artery, did stenting with good angiographic result. Type 5 in-stent restenosis is certainly the most challenging because there are very limited options available. And because these patients have already had 2 layers of drug-eluting stents. And the options in this situation is either high-pressure balloon angioplasty, brachytherapy, drug-coated balloons, or coronary artery bypass graft surgery. Brachytherapy has actually made a resurgence in the past few years due to the management of these drug-eluting stent in-stent restenosis. However, the results still remain suboptimal with 2-year risk of target vessel revascularization approaching as high as 29%. And there are patients who fail brachytherapy, in which other option is to do another brachytherapy if 12 months have elapsed, or there could be a use of drug-coated balloon. Of course, we don't have coronary drug-coated balloons available in the US. However, in this case, we used, where you see in-stent restenosis of the proximal to mid-right coronary artery, we used an off-label peripheral drug-coated balloon, which are very hard to deliver The impact balloon is delivered over a 035 wire. However, the Ranger balloons can be delivered over 018 wires. And subsequently, we got a good angiographic result, as well as good result with the ultrasound. An important mention is the Cephnus vein graft failure. We are seeing more and more of patients who are coming with Cephnus vein graft failure. And in these situations, we really have to assess the risk-benefit of treating the native coronary artery, which we know have better outcomes when we treat natives versus Cephnus vein graft, especially if they're failing. However, most of these lesions are CTOs, like in this case, which is an 80-year-old male who you can see has a functional CTO of the left circumflex artery and a CTO of the mid-LAD. He's already had multiple interventions to the vein graft, to the obtuse marginal, and LAD, which are now failing with recurrent in-stent resinosis and are not responding to balloon dilatation with already 2 layers of stent. In this particular case, we were able to wire the left circumflex artery in an antegrade manner and performed a retrograde CTO PCI of the LAD using reverse cart and final DK crush stenting of the left main LAD, left circumflex artery, with good angiographic and ultrasound result. This is a paper published recently, a couple of days ago, which is a good read and summarizes briefly the algorithm that we can use to treat these in-stent restenosis. Thank you.
That's a great talk. Thank you so much for that presentation. Panel, any other final comments? Poonam, Megha, do you have any? I actually want to ask the panel question before we let the session finish. When you do a pressure wire guided PCI, how many people do that on the pressure wire, and how often do you do a post-PCI pressure wire assessment?
I don't use the pressure wire for the PCI, but I've started using it more and more to do a post-PCI assessment. That's more if it's multiple restenosis or something like that, then I'll do a post-PCI, but I'd say probably 15% of my cases.
Rare for me to do post-PCI physiologic assessment.
I'm almost afraid to check.
Yeah, I second that. I haven't tried, but this jail wire pressure wire technique appears to be interesting because it avoids all the hassle of being, having to negotiate through the stent struts with these clumsy wires. So I might try that in the future.
Yeah, if I'm using the pressure wire, more and more I'm using that for the intervention, and then you just hook it up at the end to check it real quick. And I think we know from defined flare that a quarter of all the stents we put in are still have a residual FFR that's positive or IFR that's positive. And so if you have the tool on your table and you've already used it, use it. I don't routinely check, though. If I don't have it on my table, I generally rely on my intracoronary imaging to make sure I've got good expansion and good MSA.
Yeah, that's the final question then. So if you've done pressure wire guided PCI and you verified your result with imaging, do you do anything more? Is there anything actionable at that point? If the resting gradient is still abnormal and you don't see anything on imaging?
So if the imaging is normal as well? So it's interesting. We ran a few years ago when I was in Milan a single-arm trial called Repeat FFR. We had a lot of cases, like 2/3 on the LAD, where the FFR was still positive after PCI. And, especially in the first few cases, we insisted, we were very keen on finding out what was going on. We ran IBUS and OCT, and we could not find anything, particularly within the stent. So I think there have been other studies replicating this finding, and basically think it's all due to residual residual diffuse disease in the distal vessel. So there's nothing to be done in those cases.
And I think that's where using resting indices are helpful, because you can do a pullback and get a much truer indication if it's a focal area that you'd want to do something about versus just kind of diffuse tapering or diffuse disease, which you may leave alone if you've identified good stent expansion.
Great, that was a fantastic session. I think we'll break for now and let everybody. There was a question in the back.
Just a quick question, if that's all right. We've been talking a lot about DK crush
So
good,
the answer
good
in my case are
questions.
yes,
Ye-
yes.
yes,
So
yes, and
I
yes.
use 7 French. I can do it like ad hoc. And but the third question about bifurcation, two-stent bifurcation PCI during STEMI is anyway when there is a clot. I think it's a bad idea. I remember 2 cases of stent thrombosis, and in one, it even became a CTO because we were unable to reopen it effectively. So ACS, particularly STEMI, is a thrombotic milieu, and everything that alters the rheology of the blood around these bifurcations, and you put metal foreign bodies that are not quickly endothelialized, will increase the risk of stent thrombosis. Now we have more potent DAPT P2Y12 inhibitors, but I still think it's better to be as minimalistic as possible in STEMI and thrombus in STEMI.
Yeah, as far as using a 7 French, anytime I get into a bifurcation, I try to get a 7 French in. You can do most bifurcations through a 6 French, but it's just the hassle of having to push and pull and kinking balloons and stuff just really kind of gets to me. And so, and the vast majority of people, you can get a 7 French through their radial as well. And so with slender sheaths and techniques such as railway or balloon-assisted tracking to get a 7 French guide, through an arm or through tortuosity, it's very rare that I can't get a 7 French in, even in smaller people. So the answer is yes. I do try to do that up front, and it's the whole idea is whenever you get into any procedure, you want to anticipate the challenges that you're going to have, and doing a bifurcation and knowing you're going to do a bifurcation, but just hoping you'll get by with a 6 French instead of just taking that time and getting a 7 French in, I think is worth it. And to be quite honest, if you had to go femoral, I'd rather go femoral with a 7 French than try to battle through a 6 French through with a bifurcation case. My personal opinion.
Okay, great. Thank you so much for everybody.